Welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational virtual symposium titled Hospital-Acquired Bacterial Pneumonia, Ventilator-Associated Bacterial Pneumonia, and Gram-Negative Resistance, Pathways to Early Effective Therapy, featuring Dr. Keith Kaye as the program director and Drs. Lilian Abbo and Jason Pogue as expert faculty. Dr. Kaye is chief of the Division of Allergy, Immunology, and Infectious Diseases and professor of medicine at Rutgers Robert Wood Johnson Medical School in New Brunswick, New Jersey. Dr. Abbo is associate chief medical officer in infectious diseases at Jackson Health System and a professor of infectious diseases at University of Miami Miller School of Medicine in Miami, Florida. Dr. Pogue is a clinical professor at University of Michigan College of Pharmacy and an infectious diseases clinical pharmacist at Michigan Medicine in Ann Arbor, Michigan. In this episode, they discuss updates and challenges of optimized management of hospital-acquired and ventilator-associated bacterial pneumonia, including discussion of new treatment options for MDR gram-negative infections and strategies to minimize time to effective therapy. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what our expert faculty have to say about hospital and ventilator-associated bacterial pneumonia and gram-negative resistance.
My genuine pleasure to begin our discussion of epidemiology of HABP and VABP, and also risk factors for resistance. Let's start out with some definitions. There are various different flavors and categories of nosocomial bacterial pneumonia. HABP is pneumonia that occurs 48 hours or greater after admission, and the patient was not symptomatic at the time of admission for pneumonia, and also pneumonia that's not associated with mechanical ventilation. VABP, or ventilator-associated bacterial pneumonia, is pneumonia that arises after 48 hours post-mechanical ventilation. So patients have been mechanically ventilated for greater than 48 hours at the time that they develop pneumonia. VHABP is a category of HABP where patients have severe pneumonia, severe infection, and they sort of emergently require mechanical ventilation. So they end up mechanically ventilated, but as a consequence of their pneumonia, but they didn't develop pneumonia while on the ventilator. NVICUAP is simply a pneumonia that occurs in the ICU after patients have been in the ICU for 48 hours or greater. We're going to be mostly talking about the HABP and VABP flavors, but we may touch on our other categories as well. Let's talk a little bit about the epidemiology and sort of outcomes and burden associated with nosocomial bacterial pneumonia. HABP is a leading cause of nosocomial infection and also has a huge impact on patients' risk for death. Within the ICU, HABP accounts for about 1/4 of all the infections, and it's a huge sink for antibiotics. More than half of the antibiotics prescribed in ICUs are prescribed for the treatment of either proven or suspected pneumonia. Mortality associated with HABP and VABP is quite high, ranging from about 20% to as high as 50%. And the most severe type of pneumonia is actually the VHABP. That's when patients start out not ventilated, but because of their severe pneumonia, they urgently require mechanical ventilation. Also, ventilator-associated bacterial pneumonia is also associated with high rates of mortality. The single biggest risk factor for VABP, not surprisingly, is mechanical ventilation. And the longer someone remains mechanically ventilated, the greater their risk for pneumonia. Among ventilated patients, about 10% will ultimately develop ventilator-associated pneumonia. Patients who are in the ICU for longer durations and in the hospital for longer tend to have those rates increase by a ventilator-associated pneumonia. So again, not only is mortality greater, but lengths of stay are impacted by ventilator-associated pneumonia. And also, not surprisingly, the cost of hospitalization. Some studies have estimated about $40,000 of attributable costs to the ventilator-associated pneumonia in a given case. Gram negatives are a huge player in the HABP, VABP world. There's a nice survey by the U.S. National Healthcare Safety Network that basically studied these types of pathogens from 2015 to 2017. And almost half of hospital-acquired pneumonia and almost 60% of the ICU-acquired pneumonias were due to gram-negative bacteria. In another analysis, greater than 2/3 of the isolates in ICU pneumonia were gram-negatives. And by and far, the single most common organisms are Pseudomonas and Enterobacterales. Among the Enterobacterales in the pie chart, you can see Klebsiella in green, E. coli in purple, Enterobacter in sort of that orange. Those all are Enterobacterales. Those together make up a big chunk of pneumonia, and Pseudomonas is there in red, is the single most common gram-negative pathogen. Don't forget about Staph aureus and MRSA within Staph aureus account for almost a third of these pneumonias. We will be focusing in and honing in on the gram-negatives today. The gram-negatives, we often say for gram-positives, we might need better drugs to treat some of our resistant gram-negatives, but sometimes we really get to the point where we need any effective drugs to treat our gram-negatives. And I think resistance in the gram-negative arena is really a crisis in healthcare. The three bad boy groups of resistant gram-negatives, each recognized by the CDC threat category risk with regards to resistant bacteria. Pseudomonas, the granddaddy of them all in terms of nosocomial gram-negative infection. It has intrinsic resistance abilities and also can acquire resistance determinants. Infection can be associated with biofilms. This is a bad player. CDC has categorized multi-drug resistant Pseudomonas as a serious threat. Enterobacteriaceae, and now we call it Enterobacterales. This is an older, the threat report came out before they sort of changed the name. But within the Enterobacterales, Klebsiella is probably the single most common bacteria that we see that could be carbapenem resistant. So Klebsiella is the most common type of CRE or carbapenem resistant Enterobacterales that we see, which is associated with high morbidity and mortality. But don't forget about the ESBLs. These are the extended spectrum beta-lactamase producers, most commonly seen in E. coli and Klebsiella pneumoniae. While these can be treated by carbapenems, treatment options are limited. And the more carbapenems we use, the more resistance we'll see, particularly in organisms like Pseudomonas. ESBLs are also associated with poor outcomes and increased hospital costs. ESBLs have been categorized as a serious threat by CDC, and CRE has been categorized as the highest threat level as urgent. Finally, we have Acinetobacter baumannii, which is an opportunistic pathogen most often found in ICUs. You often see them in burn ICUs. You can see them outside the ICUs, and these are organisms that also can go from susceptible to resistant very quickly. Multi-drug resistance is fairly common, and CDC has categorized carbapenem-resistant Acinetobacter as an urgent threat, which again is the highest threat level that CDC assigns. Why do we care so much about antimicrobial resistance in the ICU? Well, we know that delays in the implementation of effective antibiotic therapy equals bad outcomes. Delays in the time to effective therapy, or TTET, has been independently associated with longer length of stay, both in the ICU and the hospital, longer time to symptom resolution, things like fever, also improvement in oxygenation, and of course, increased mortality. So you really, when you're choosing your antibiotics in severe infections where gram-negatives are going to, in all types of infections, we're going to focus on these gram-negative severe infections. You really want to choose a regimen that's likely to be effective. And remember, we don't know what we're treating right away. Even with rapid diagnostics, which we'll talk about, there's always an empiric phase. And getting it right during that empiric phase can really save lives or really improve outcomes. And one of the things that you need to focus on is the likelihood of antimicrobial resistance when you're choosing that therapy. And prior antimicrobial exposure and history is a very important predictor of antimicrobial resistance, as are comorbid conditions, time in the hospital, as well as local epidemiologic patterns. That's, antibiograms, which we'll talk about in a moment, can be very important players in helping you to determine what antibiotics might be the best choice. In cases of hospital-acquired pneumonia and ventilator-associated pneumonia, really want to consider risk factors for multi-drug resistant pathogens, because if you look at those risk factors that we listed in that sort of first bullet on the right we just talked about, these are very common risk factors that we see in our patients. Comorbid conditions, they've often had prior antibiotics, and they've often been in the hospital for quite a while. We know we often have to start broad in HABP, but it's also very important to circle back a day or two or three afterwards and narrow that therapy whenever possible. We will talk about this in detail a little bit later. Just to hammer the point through that early appropriate therapy or minimizing that time to effective therapy improves outcomes. This is a really nice study by Iraqi et al. From CHEST. They compared patients with ventilator-associated pneumonia who got early effective therapy. That was the bug drug. The drugs were active against the bug. Again, in the empiric phase, you don't know what the bug is, but subsequently it was determined that empiric therapy was effective. And in red, you can see delayed therapy. This is when the initial therapy either wasn't appropriate or effective therapy wasn't implemented in a timely fashion. You can see in the blue group or the early effective therapy group, it was about 12 hours after the diagnosis that they got effective therapy, and that more than 24 hours in delayed therapy group. And that doesn't, we're talking about 12 to 16 hour difference. It's not that in our lives, it doesn't seem like that much time, but in a critically ill patient, it can really be a lifetime, literally. And when you compare the delayed intervention group in red to the early intervention group in blue, y-axis, we see mortality, a significant risk factor for increased mortality with delayed effective therapy, greater than 7-fold increased risk. So getting it right early is important, but we also know we can't willy-nilly throw around our broadest spectrum antibiotics all the time because we will then run out of our options. So we need to be prudent but thoughtful about that early effective therapy and when and how broad to make it. IDSA and ATS have guidelines for the treatment of HABP and VABP. These were published in 2016. And what you'll see is whether you're talking about VAP due to multi-drug resistant organisms, HAP due to multi-drug resistant organism, or specifically multi-drug resistant Pseudomonas, HAP or VAP, the one common risk factor that's shown in bold is prior IV antibiotic use within 90 days. Prior IV antibiotic use not only gives that patient high systemic antibiotic exposure in the recent past, but also is associated with likely hospitalization and comorbid conditions. So it's a common, important risk factor that you need to think about with your patient when you're treating HAP-VAP. Just to remind you about our patient, poor Scott was in a car accident. He was intubated for airway protection, but now on day 5 is febrile, has new yellow thick secretions, has an oxygen requirement that increased from 40% to 60%. Chest x-ray shows a new right lower lobe infiltrate. He has leukocytosis, which is new as well. And we know that in terms of prior history, he was in the hospital about a month prior for pneumonia versus COPD. He did receive inpatient piperazole and tazobactam, and he also received a 10-day course of oral levofloxacin. Let's talk a little bit about antibiograms. We saw that when you're assessing your empiric therapy and you want to determine the likelihood of antibiotic resistance, or you want help in picking an antibiotic that is most likely to be active against gram negatives, the antibiogram can be a huge help. We'll show an example in our patient in a few slides. But, antibiograms, we most commonly think about hospital-wide antibiograms, which I think many or most hospitals, at least in the U.S., publish these usually annually. And it's basically gives you a list of different organisms and different antibiotics and the percent in the hospital of those organisms that are susceptible to a variety of different antibiotics. There are different variations of antibiograms that might be even more helpful than the hospital antibiogram. There are unit-level antibiograms. Most commonly, you'll see these in ICU antibiogram because often the organisms seen within the ICU are more resistant than those seen outside the ICU. So, you might have pseudomonal susceptibility to ciprofloxacin of 90% outside the ICU, hospital-wide, but within your ICU, it might only be 50% susceptible. So that unit level can be very useful, and you might even have different antibiograms for different ICUs. You might often have different resistance patterns in a surgical ICU as compared to a medical. Limitation of the unit level antibiograms is sometimes the numbers of organisms can be quite small. So the precision of those susceptibility estimates sometimes can be a little less, can have wide confidence in margins as opposed to your hospital-wide where your denominator might be larger. Combination antibiograms, I think, are particularly interesting, even more so when we're talking about an organism like Pseudomonas. These provide susceptibility rates for a combination of antibiotics. That's saying if I'm receiving ceftazidime in my hospital and a patient ends up having Pseudomonas, and let's say it's only 75% susceptible to ceftazidime hospital-wide based on the last year of data, what if I add levofloxacin? How likely is that combination going to give me at least one active agent against Pseudomonas? And how about if I add gentamicin? So we'll show some examples here. These combinations, since we often think about double coverage of Pseudomonas, we'll talk about that in a bit, during the empiric phase to try to make sure that we increase our likelihood of providing effective coverage against resistant organisms like Pseudomonas, these combination antibiograms can be quite informative. There's also real-time antibiograms, where instead of having an antibiogram that might be 6 months or a year old, through automated data and the EMR, you actually, the antibiogram can be updated sort of in real time. It won't tell you necessarily what things looked like in the hospital with Pseudomonas a year ago. It might tell you what they look like right now or in the past week or the past month. So these can be very powerful, also require definitely some serious IT support and hospital support to get these implemented. This is an example of a combination antibiogram. This is for Pseudomonas aeruginosa. Just to orient you guys, green means a single agent. Purple is an agent combined with fluoroquinolone, and yellow is an agent combined with aminoglycoside. So here you have the percent susceptible, the percent of Pseudomonas susceptible in this example, in this hospital. And ESC is an extended spectrum cephalosporin. Carb is a carbapenem. TZP is piperazole and tazobactam. And then we have aminoglycoside is AG and fluoroquinolone is FQ. You can see outside the ICU, if you're using an extended spectrum cephalosporin like cefepime, let's say, it might have 80% susceptibility. Pseudomonas might be 80% susceptible alone. And if you combine it with aminoglycoside, that susceptibility increases to 90%. So that might say, wow, I might want to provide double coverage if I'm worried about pseudomonal sepsis, and I might want to use an aminoglycoside with cefepime. A quinolone would get you to about 85%, but not as high as an aminoglycoside. And similar trends where combinations with aminoglycosides tend to give you the greatest bang for the buck when they're combined with another single, in this example, beta-lactam agent. When you look within the ICU, not surprisingly, susceptibility rates are lower than outside the ICU. We kind of talked about that. One of the reasons we find value in a unit level antibiograms. Again, you can see increased susceptibility with the combination with the aminoglycoside. That gives you the biggest bang for your buck, the biggest increase in activity of the combinations that are profiled here. So at this time, I want to invite my faculty members here, Drs. Abbo and Pogue, and I want to sort of ask them, maybe start out with Lilian. What are your institution's guidelines for antibiograms? Do you have unit-specific ones? How do you use your antibiograms in your hospital?
Hi, good afternoon. So our antibiograms are done once a year. We have a very large health system. And in order to collect for a certain number of isolates for certain units, it has proven that we get the biggest bang for our buck when we look at things annually. In some units that are smaller, for example, some of the pediatric units, your NICUs, you may not have enough isolates if you're doing it every 3 months or every 6 months, but there might be other areas like your ER where you can do them more often. So we tend to do them once a year. We do unit-specific antibiograms and hospital-specific antibiograms. And in addition to doing the unit-specific by location, we also do by source. So for example, for the emergency department, we have urine-specific antibiograms and blood, as we don't want to merge respiratory cultures with urines. We also have for the ICUs, we look at blood and general non-sterile sites. So we do that once a year, and they get distributed to the entire medical staff. And we also have an app and a website where people can access them at any time.
Jason in Michigan, anything to add or any other comments that you'd like to make?
Yeah, I largely agree with what Lilian said, and your presentation was excellent as always. And I would just plug that, again, when you're talking about a disease state like VAP or pneumonia in ICU patients, as you showed, appropriate empiric therapy is one of the most important things that we can do. It's probably the most modifiable risk factor for bad outcomes that we can do something with. So I'm a big proponent of unit-specific antibiograms. Combination antibiograms, as you showed, I think are very valuable. Lilian talked a little bit about this, but I do think it's important to separate out by ICUs. We've done that both when I was in Detroit, now when I'm in Ann Arbor, and you can see that, kind of the ideal empiric regimen is going to be different in the ICU or in the SICU versus the MICU versus the burn ICU. And when I was in Detroit in our 8-hospital health system, it was even that way from hospital to hospital. And so the empiric therapy recommendations were different across the board. And one thing that I'll highlight that we didn't really talk a lot about in the slide deck is that, again, if you're talking about wanting to optimize empiric therapy for gram-negative pneumonia, a Pseudomonas-specific combination antibiogram is nice, but that's only one of many pathogens. And Lilian kind of hinted at this a good bit, but the way that we always do those combination antibiograms, we say, okay, if a patient's going to have pneumonia, so I'm interested in respiratory cultures, I want to know how combinations fare against all gram-negatives that are cause of pneumonia in the ICU. And so we'll do that. So we'll include the SUDS, the E. coli, the CLEB, everything else. And then you're really able to figure out, at least for the unit, what that optimal empiric regimen is, and then kind of add that to the patient-specific factors as you talked about before.
Back to our case, this is the ICU where Scott is. This is the antibiogram specific to his ICU. These are the number of isolates tested. These are the different antimicrobials. And you can see for Pseudomonas, as well as the other gram-negatives, a lot of your broad-spectrum, extended-spectrum cephalosporins and inhibitor combinations, ceftazidime and piptazo, are going to give you anywhere from the mid-80s to mid-90s activity. Your carbapenems, for Pseudomonas, you have about 80% activity for meropenem. For your other enterobacterales, it's closer to 98 to 100%. And you can see ciprofloxacin is about 80 to 90% active. And your aminoglycosides go anywhere from 80s to the high 90s, amikacin being particularly high as well. And this is what the IDSA ATS guidelines say. You can see for MRSA coverage, if there are MDR risk factors, like we discussed, you would want to cover MRSA. And you, regardless of resistance risk factors, you always want to give at least ideally one beta-lactam with anti-pseudomonal activity. If there are risk factors for resistance, like there are in our patient, there are risk factors due to his Zosyn exposure in the hospital, the IV antibiotics, you would want to give one from this group, one of the beta-lactam agents empirically, combined with another anti-pseudomonal agent from a different class. And typically that would either be a fluoroquinolone or an aminoglycoside. And this is where those combination antibiograms and your hospital unit-specific antibiograms can be quite helpful. Just a quick shout out, there are European guidelines for HABP, which came out in 2017. They also base therapy on risk for resistance. They also factor in the severity of illness, I think, in terms of the need for double coverage for gram-negatives to a little bit more significant degree than do the IDSA ATS guidelines. I just wanted to let you know that those are out there as well. So back to our faculty discussion, just a couple minutes. I would like to know from Jason and Lily, let's start with Jason, what would you have chosen in this patient for empiric therapy and maybe why? And we'll just try to give you a minute and Lilian a minute to discuss.
I will try to be quick for you, Keith. So yeah, I think it's a good question. And as you stated, all of those are reasonable. But so kind of three things come into this, right? So the first is patient-specific factors. So patient-specific factors are recent piptazo, recent quinolones. So again, piptazo, probably not something that I want to use empirically. And the recent quinolones also makes me start thinking ESBL. Do I need to be considering that in this situation too? Second is that ICU antibiogram that you showed. And again, it was pretty much consistent with that. You had for Klebsiella enterobacter, 15 to 20% rate of ceftriaxone resistance. So some concern for ESBL there. your anti-pseudomonal of choice 15-ish% resistance as well. So that's part 2. And then part 3, and I think it's really important for this case, is the patient's also a little bit unstable, right? Their oxygenation was worsening. And so again, then getting it right up front is so important. So I put that together, and what I'll probably do empirically in this patient is go vanc mero tobra. Mero to, again, not be giving pip, tazo, or cefepime, which is kind of the same thing in a lot of ways from an empiric standpoint, giving me that ESBL coverage, and then that tobra just because I want to make sure I'm right up front.
How about you, Lilian?
I agree with Jason. I have the same concerns. I also know my local patterns of resistance. So I look at the individual patient antibiogram, precision medicine, what is the right drug for the right patient at the right time. And I also look at what's the prevalence in my community. So if I am in my main teaching hospital versus in a smaller community hospital within the health system, I may feel more comfortable with going straight with meropenem. With another, I may say pip tazo may still work, or cefepime. I think one of the things that in your questions is what is not addressed in the guidelines. I think the rapid diagnostic test, which we're going to be touching upon today, and how can they help you de-escalate that vancomycin? If you don't have MRSA, how can you stop that quickly? Or if you have to escalate, if you have a carbapenemase producing organism, why meropenem would work or would not work?
Awesome. Well, with that, Lilian, don't go anywhere. It's my true pleasure and honor to turn the podium over to you to talk about antimicrobial resistance in HABP and VABP. Take it away, Lilian.
Thank you, Keith. And the honor is truly mine. I want to thank you and Jason for being amazing co-hosts, and for Clinical Care Options for having us. So I'm going to move forward, and that's going to be a rapid fire session. We're going to be talking a little bit about how antimicrobial resistance and the epidemiology, how is this affecting all of us? So it's not a problem isolated to Michigan, New Jersey, or Miami. This is really a global problem. We know that over the last decades, antimicrobial resistance has affected globally every patient in every unit. And by 2050, the estimates are that if we don't do something about it, there will be over 10 million deaths per year, including over 300,000 deaths just in North America. So this is a serious problem. And now with COVID and the rampant use of antibiotics in many areas, we're seeing more spread of resistance. So really careful. We need to pay attention which drugs we use and use them wisely. We also know that antimicrobial resistance, particularly in gram-negatives, has really gone up both in the community, non-ICU, and in critically ill patients. And this resistance is across multiple classes of antimicrobials. If you look at our carbapenems, non-susceptibility went from 20 to 60%. That's a significant increase. The same thing with our broad-spectrum beta-lactams. So look at your cefepimes and you got your pip tazo, really significant increases on antimicrobial resistance in a period of maybe 10 years or less. So we really need to use our drugs wisely, as we're not getting 20 new drugs in the market every year. The definitions of multi-drug resistance have evolved over the last years as well. For the purpose of this talk, we're going to be using the definition that resistance is when you have resistance to less than 3 groups of antibiotics. MDR, or multi-drug resistant, is resistant to 3 or more groups of antibiotics. XDR, extreme drug resistant, is more than 3 or equal to 3 and sensitive to less than 2 groups of antibiotics. And PDR is pan-drug resistant. It's resistant to all groups of antibiotics. And these isolates were tested against all agents in every category. And unfortunately, those are becoming more frequent and more difficult to treat. We also know that in pneumonia, HABP and VABP, MDR organisms have increased globally. And the WHO gives the highest priority to develop new antimicrobials for carbapenem-resistant strains of Acinetobacter baumannii, Pseudomonas, E. coli, and Klebpneumo. The microbiology is going to vary by country, by hospital, by patient population, by the prior history, as we discussed in our patient, and the type of ICU. The burn ICU may be very different from my medical ICU or my transplant ICU or even a cardiac ICU. The top resistant gram-negative pathogens that we're going to see, usually pneumonia, it's Pseudomonas at the top of the list. And then we have, in some areas, we may see multi-drug resistant or extreme drug resistant Acinetobacter, which usually stays in the environment. And once you have it, you really not only need to treat the patient, but also the environment. E. coli and Klebsiella, including your EXBL and your XDR Enterobacteriaceae. We know, just talking about Pseudomonas, multi-drug resistant, that the mechanisms of resistance are going to be multiple. And I'm not going to go into detail into each of these, but we know the most frequent ones are going to be AMP-C, which confers resistance to penicillins and early generation of cephalosporins. Then we have the MEX-AB, OPRM upregulation, right? And that's going to give you some resistance to some carbapenems, but not others, and reduce susceptibility to your penicillins. Then we have OPDR downregulation that also contributes to your carbapenem resistance, our ESBLs and carbapenemase producers. And we know our carbapenemases, our Verona integron metallos, which are the VIMs and the IMPs, are really spreading more widely. And that is a problem as we have not only resistance to carbapenems, but also penicillins, cephalosporins, as trionems. And then we have other mutations. So just to simplify, Pseudomonas is a complex organism with multiple mechanisms of resistance, porine mutations, we have carbapenem productions, AMC, other enzymatic modifications. So that becomes an opportunity and a challenge as we need to know how to target the right drug to treat the organism, depending on the mechanism of resistance that organism is expressing at that time. We also know that, as you can see in this slide, it's a very busy slide, but you see different antibiotics. And for different antibiotics, what we can see is that in teal, we're going to see the ceftolozane tazobactam. And we're going to see that overall, across the board, depending on the mechanism of resistance, this is one of the drugs that sort of remains active compared to some of the others. But depending on the mechanism of resistance, aminoglycosides may still be preserved compared to other agents. So just again, understand that Pseudomonas is a complex bug. It's very smart, expresses multiple mechanisms of resistance, and we need to understand which drug to target in order to treat that patient with your pneumonia in a timely manner to improve survival. Well, we also know at the Enterobacteriaceae, we know that the mechanisms of resistance are perhaps less complex than Pseudomonas, but also we have the extended beta-lactamase producing enterics, and then we have the carbapenem producing enterics. From your ESBLs, we know that the most common are Klebsiella pneumoniae, Klebsiella oxytoca, Proteus, E. coli, and also we know we're going to see most frequently in the US the CTXM15, but in other parts of the world that may differ. As a proxy, people tend to use an MIC of greater than 2 against ceftriaxone to sort of predict this might be an ESBL producer. But that isn't always true. And then the carbapenemase production is usually when we see resistance to more than one carbapenem or a carbapenemase producing organism, if you have the molecular test to diagnose it. Most frequently we see it in Klebsiella, but nowadays we've seen carbapenemases almost in every gram negative. And there are other carbapenemases like your VIMs, your Verona integron, your New Delhi metallobeta-lactamases, and your IMPs. And then we have the OXA48. So again, very challenging. It looks like a soup of letters, but you really need to understand the mechanism of resistance. And as Jason is going to show us later, you need to understand how each drug targets a different mechanism and why one drug may be better than another, depending on the situation. And then we have the CRABs, the carbapenem-resistant Acinetobacter. Usually we see OXAs and OXA-like mechanisms of resistance, but may also have beta-allos and beta-lactamases. And again, very challenging to treat once you start seeing resistance to all beta-lactams and carbapenem. So now I'm going to bring my two co-speakers to really discuss a little bit, what's the experience with resistance in your hospitalized patients and which resistant gram-negative bacteria do you see most commonly? So Jason, would you like to start with the first question?
Yeah, I'll jump in and give my experience. And I think for our audience, the key thing that I would say is two things. One, you're going to get a US-centric response to this question. And as part of that, it's really important to know what locally your issues are. But for me, I would say today, the two that I see are multi-drug resistant Pseudomonas and then ESBL producers are the two biggies. But as Keith can tell you, when he and I were in Detroit back in the day, circa 2010, we had an issue with carbapenem-resistant Acinetobacter, which was a real nightmare to deal with. CRE briefly came on the scene for us. And really understanding and knowing what's around locally is the biggest, most important thing that we can do. But I would say that the problematic players that we see are MDR sued just because of the number of patients. And then again, when you're dealing with E. coli being the pathogen, it's the infection that is so much more frequent than anything else. If you have a 10% rate of ESBL production, that ends up being a lot of patients. And so I would say that those two are the ones that I predominantly deal with.
Thank you, Jason. How about you, Keith?
Yeah, so Jason and I tend to follow each other around. We were in Detroit together in Michigan, but I'm in Jersey now. I'm in the Northeast, and still, Pseudomonas, it's pretty much everywhere. Jason and I co-led an international study looking at XDR gram negatives. And the one common factor was that Pseudomonas was pretty much everywhere. CRE, more some places than others. Acinetobacter certainly is more places than others. Pseudomonas is notorious for a reason, but it's pretty much everywhere. And I'll echo what Jason is saying about the ESBL producers. And we tend not to worry about them because we have carbapenems to treat these. But their frank number and the degree of carbapenem use and the amount of IV antibiotics that we're requiring to use in these patients, more and more of whom are having community onset infection, is really striking and concerning. The other weirder organism that pops up sometimes is Stenotrophomonas. We're not going to talk a lot about that today, but I think particularly in transplant populations and in some of the ICUs, steno is not unusual to find either in the blood from a device-related infection or from the respiratory tract from either colonization or pneumonia. So I'll leave it there, Lilian.
Yeah, thank you both. And I completely agree. And one of the other challenges that we don't have too much time to discuss today is there are not really good oral options to step down these patients, right? So wearing my hospital administrative hat, now you're trying to decrease your length of stay, you're trying to decrease costs so you can bring more care to others. And then how do you do this, right? You have to set up home healthcare. You have to, bring IV infusions or keep the patient in the hospital, which is also a challenge. All right, so we're going to keep moving. So when we discuss mechanisms of resistance, how do we merge, right? How do we bring the bench to the bedside? How do I know which drug I need to use? And how do I get those susceptibilities? So there are different ways of doing it. And I'm not going to go into detail, but at our hospital, there's a great collaboration between infection control, antimicrobial stewardship, and the microbiology lab. And over time, we have really looked at how can we improve this time to effective therapy. When I started, we didn't have rapid diagnostic tests. So you will get your respiratory culture. The patient, Scott had a sputum, then that sputum has to grow. Once it's growing out in the plate, then we have to wait 5 days to get, a bacteria identified, and then the susceptibilities, and then it's pan resistant. So now I need to call the lab again, and it's a weekend. Now they need to set more and more, discs and e-tests to figure out which combination therapy will work. Well, we created this rapid diagnostic test algorithms, which really provides upfront information to the lab technician. And we do it based on the source of the specimen. So if it's blood, we use BioFire. And if we use non-sterile sites, depending on the organism, we'll use different platforms. So we pretty much, what we're looking is for targets. We're looking for rapid diagnostic target genes to see if there are carbapenemases produced or not. And if there are carbapenemases, then we go through different routes and test different antibiotics. And we use sensititer or some other methods in order to very quickly identify through microdilution which drugs would be best. In some cases, they can do some synergy and tell us very quickly which combination will work better. That has cut the time significantly, and that gives us a chance to give that empiric therapy in much faster time and target with the right antibiotic and not finding 5-6 days later that I've been treating the patient with the wrong drug. This is a sample that we use for the non-sterile sites for the VITEC, and this last one is for sterile sites other than blood. All these slides are available in your slide deck, so you can review them later. So other important thing is that the rapid diagnostic test is specific for HABP and VABP. And there are different tests that can analyze respiratory secretions and look at common organisms, and we can look at bacterial, viral, and fungal. You use the specimen, and you don't need to wait for it to grow in a culture. And with high accuracy, you may detect many organisms that sometimes we cannot find in a culture. Just look at the COVID pandemic. If we were waiting to culture the virus, which many of us don't have a level 3 biosafety hood, we would have never been able to detect this. So having PCRs, having rapid diagnostics has really revolutionized infectious diseases and how we treat patients. It also gives us the potential to tailor therapy and escalate therapy appropriately or de-escalate. So if I don't find Staph aureus, I might be able to de-escalate quickly that gram-positive coverage. And the challenge here is that most of the data really shows rapid identification, but we still don't know what's the improved antibiotic use or the clinical benefit. That's where we need more studies, and they're underway. And some negative test results for some pathogens may be misleading if no resistant determinants are identified. So they're not perfect, but they do offer a significant amount of guidance in some areas. And again, they're not widely available, and there is also a cost associated with them. So we really need to be careful. We also know that there are different molecular tests approved for pathogen and resistance detection. For example, BioFire FemArray has a pneumonia panel in BAL and sputum, and then Univero LRT has some other panels for BAL. These differ in that some of the panels have 15 common bacteria, others have 20, and the organisms that are found in each panel and the mechanisms might be different. When you're implementing a new test, you also need to work with your lab and understand what's the hands-on time and what's the turnaround time, right? So one test has a 75-minute turnaround time, the other one has 5 hours. So you also need to adapt the test to your lab, to your patient population, and which one will give you the best cost benefit. Both panels not only detect bacteria, but also some of them have viral targets, others don't. And as I mentioned, the turnaround time may differ. So you need to target it to the population and your local needs. A very important slide, and this is one of my favorite studies, is Mesakar, published in 2017, how, rapid diagnostic tests and rapid stewardship, and we call it diagnostic testing and stewardship of testing, really can improve the conservation of resources and at the same time improving care. So it's really important as you're trying to implement this rapid diagnostic test or your stewardship of testing, you have to have algorithms and really streamline how the results are going to help you with direct patient care and direct information. If I have a rapid diagnostic test that is just going into my electronic medical record and the results are coming at 11 p.m. at night and nobody's looking at them until 7 a.m. the next day, it may no longer be a rapid diagnostic test. So you need to figure out, as this graph shows very nicely, you have the patient, you need to do a clinical evaluation, and you need to have your diagnostic stewardship. Which one is the test that I need to send? How fast am I going to get it? Is this the right patient? And is this the right time to send this test? And once you order it, you need to work with your lab to understand what's the turnaround time. Once they receive the sample, are they batching them or are they looking one test at a time? What's the result and how is it reported? And then how do I interpret these results? Who is interpreting and how is that changing therapy? Who's making that call at the bedside to tell the nurse and the providers, hey, you need to change therapy because the rapid results just came back. So this is really a cycle, and really it has to be well ingrained and very well thought through. Otherwise, you're just adding cost and adding tests, but not acting on the results and not optimizing therapy. So I want to reiterate how important is the partnership between the microbiology lab, your stewardship team, your clinical team, and of course, infection control when we need to isolate these patients and ensure that we don't, transmit horizontally these organisms across the facility. So now I'm going to bring Keith and Jason again. I want to ask both of you, what is your experience with this rapid diagnostic test in general? What do you consider the most valuable information provided? What other information do you think is needed to support the widespread adoption of these tests in hospitals and ICU, specifically for pneumonia? And then how can we steward the appropriate use of these resources, as these tests are expensive and we want to make sure that people are using them wisely, not just to detect colonization. So this time I'm going to start with you, Keith, if you can give us your opinion.
Lilian, I think my most experience has been with bloodstream infection. I think the example that you gave with one of your algorithms was actually an RDT in positive blood culture. Pretty much all the RDTs that are available, with a few exceptions, really require growth of the organism. And then you can, pretty rapidly determine what the pathogen is and also some genotype for different resistance determinants, whether an ESBL is present or a carbapenemase. I think for pneumonia, as you had covered really nicely, it's a little bit different because you're getting it directly from specimens. So you don't have to wait for the growth in a day or two or however long it will take. And it's even more rapid. So I think it's particularly exciting. But to be honest, I don't think that the HABP panels that you described have been widely adopted. I know there are some academic centers that use these, but I don't think they're being routinely used. I think the most valuable information that I get, first of all, is the pathogen, right? You know what the pathogen is immediately. You also get some resistance determinant information. I think, for Pseudomonas, unfortunately, as you had covered nicely, you aren't always going to see a carbapenemase. You rarely see a carbapenemase mediating carbapenem resistance. It's more likely due to other things like foreign mutations or pumps, and a negative result, or saying I have Pseudomonas and I don't have a carbapenemase. That doesn't mean that carbapenems are going to be active. So I think particularly with a respiratory panel, although I don't have experience with the HABP panel, I think the identification of the organism itself is still, and then you link that to your antibiogram, your combination antibiogram or whatever, and I think that provides valuable information. And before I turn it over to Jason, I'll just say there's a European study going on showing how rapid diagnostics in HABP impact treatment and impact patient outcomes. And I think we're going to need, in order to make the case to whether it's P&T or whether, as you mentioned, admin, Lilian, wearing the admin hat, whether it's to quality or to administration or to the CFO, we're going to have to show that these aren't just a new fancy tool, but that there's an infrastructure plan to utilize these and interpret them appropriately and efficiently, and that they can make a difference, that there's data out there, there's real world studies that show that they can impact outcomes. How about you, Jason?
That was an awesome answer. I would just add or reiterate a little bit. Again, my experience has been great. My experiences with blood, and to be honest with you, bloods are easy because gram negatives in the blood matter, right? I'm not thinking it's a contaminant or it's not relevant or any of that stuff, right? And so I know it means something. And then the key resistance determinants that are picked up for common organisms in the blood. Again, that's predominantly in Enterobacterales that you're going to see in that situation. So getting information like CTXM positive or negative, carbapenemase positive, negative really helps you escalate in patients who need escalation because it's positive. And if you actually do some work, you can actually get to some de-escalation pathways based off it as well. And so my experience has been great, and it's improved the care of patients, and there's no doubt in my mind that it's saved lives. I think the pneumonia stuff gets a little bit more challenging. And the thing you guys both touched on, and I think is really important for the audience to remember, is it's really important to remember what the RDT tells you and what it doesn't tell you, right? And so when you move into pneumonia, the one that you guys both brought up is it a pathogen causing the infection? Again, we need to learn that type of information still. But again, depending on the organism, and again, Pseudomonas becomes the big player here because the mechanism of resistance are usually chromosomal upregulation of different mechanisms, whether it be porin downregulation, efflux upregulation, or AMP-C hyperproduction. That's not detected. And so you're going to often get a situation where it's Pseudomonas, no resistance determinants, and then you're going to have to figure out what to do still. And so all the things that we talked about before, patient factors, ICU factors, become important. So it's really important that if you adopt these into your practice, know what they tell you and know what they don't tell you, combine that with the patient-specific scenario and make the best case for that patient, or make the best care for that patient.
That was fantastic, both of you. And as like you mentioned, we may be able to detect an organism, but then we still need the susceptibilities. And what if we detect it, but then it doesn't grow? So that's also a catch when we always implement this test, like, now we have a discrepancy. So thank you so much for those great comments. So shout out to infection control, because really it's also the cornerstone of antimicrobial stewardship. And if we don't prevent the infections, then we're going to continue to use antibiotics. So I always say, if you prevent the infection, your stewardship program is going to do way better. And that also includes hand hygiene, avoiding this horizontal transmission. These organisms, these gram-negative organisms, are not aerosolized. They're not via droplet or airborne. They're really through contact. It's your respiratory therapies, going from bed to bed, nebulizing patients, and maybe forgetting to change, gloves and wash their hands before they touch the ventilators. Your contact precautions, some of your droplet precautions in some areas, especially when you have respiratory viruses. And then these organisms really complicate things. You need to move patients, cohort them, isolate them. We have created banners, alerts, special color signage. So really make sure that you're working with your infection control teams, as you as clinicians maybe or pharmacists maybe going from one place to another, treating patients. If you see patterns and trends, work with your IPs and try to tackle this. And then other important things is that we know that all these preventive efforts to reduce resistance have been working. It takes time to see the results. But since 2013, there has been dramatic reductions in the number of multi-drug resistant gram-negative organisms. But we still, as we said at the beginning, we have room for improvement. So we just want to have a very short discussion before we go into Jason's session. But algorithms, how are some of you using algorithms and antibiograms to use these rapid diagnostic tests? And what are the approaches that you're using in your ICUs to prevent HAP and VAP? So we know about oral care, keeping the head of the bed elevating, removing the ventilator, right? If you don't have a ventilator, you don't have HAP and VAP. But what else would you do? 30 seconds, Jason, and 30 seconds, Keith.
30 seconds. So I think things like sedation holidays are becoming more popular. Again, anything that's a risk factor, what you can do to limit if it's not a benefit. to the patient. And again, I will just highlight on the algorithm piece, I do think empiric pathways are critically important, using that unit-specific information to drive it. Again, we have algorithms based off of what the Verigene test shows, right? And I think that's a good starting point, but they ain't perfect, right? And so it's really important that that's really combined with detailing the frontline clinicians and real-time stewardship intervention to really optimize the care of these patients.
And I agree, of course, with everything that Jason said. The other thing with prevention of hospital-acquired pneumonia, particularly ventilator-associated pneumonia, is avoiding intubation. So use of BiPAP or CPAP, as Jason's saying, looking for that window to get them extubated. So avoid intubation and then try to get them extubated as quickly as safely possible. One thing I'll mention, which I've mentioned before, Lilian hit hard, and Jason also mentioned, algorithms, you start getting into RDTs and expensive stuff. They will not work if there's not an infrastructure to educate, to feedback, and to include your frontline users in these guidelines or in the RDT interpretation. So having the infrastructure, not just having a product that you throw out there or a process, but actually making sure from a QI perspective that the cogs in the wheel are moving together, and that that the messages are getting interpreted correctly and efficiently, and that they're reaching the bedside. So I will stop there.
Thank you. So with that, those great comments, we're going to turn into Jason's, who's going to teach us about antimicrobial agents and the latest data.
All right. Thank you. And again, I want to reiterate what my colleague said. I really want to thank everybody who's joined us today and CCO for putting this on. I'm here to talk about the new agents. We're pretty blessed here, I think, that we have a number of new beta-lactam agents for the treatment of MDR gram-negative infections. And one thing that I also think is worth noting, and we're going to talk about a little bit here today, is that one thing that's pretty cool is that for 4 of them, we actually have pneumonia data as well. And that's kind of atypical. Usually we have to extrapolate, PK/PD and penetration information, in vitro susceptibility, to make a pneumonia determination. And it's really nice that we have all of those data for these agents. And so we're going to get into that a little bit here today. Again, it'll be a rather high level overview just because we don't have all day to do so, but the references will be there for you if you want to dive deeper, and we're always available for questions as well. And so before we get into that information, let's go back to our case. And I want to see what you guys want to do now in this situation. So again, remember we had Scott. Scott had a new onset pneumonia, right? And we had that discussion about what we would place the patient on. And it turns out that the team went with vancomycin, again, a very common and reasonable recommendation to give Scott. Unfortunately, over the next 24 hours or so, Scott fails to respond rapidly. And you're concerned that his infection might be due to a resistant organism. I think that would absolutely be in your differential at this point in time. The ICU antibiogram, right? We talked about that to get some of our information to try to figure out what to do next. It's about a year old, and it shows moderate level of carbapenem-resistant Pseudomonas. Let's just say that 20% resistance to carbapenems, cefepime, piperacillin, tazobactam. And we're fortunate enough to work at an institution that does have RDT, so rapid diagnostics. They show Pseudomonas, so we see that it's Pseudomonas, and it's negative for carbapenemases. I want to bring real briefly Drs. Kaye and Abbo back on and get an idea what you would do. So I'm going to start with you, Lilian. What would you do in this situation?
So I think, again, going back to our history and what we know so far, and after hearing your talks, I think I'm maybe persuaded to pick C, Voltazo plus obramycin.
Keith, what would you do at this point?
I can say in reality, given the fact of, things like our guidelines and culture and maybe pharmacy budgets and the impact that they might have or pressure that we might receive, I probably would go to meropenem tobramycin, even though I got to say ceftolozane tazobactam plus Tobra is certainly catching my eye as well.
All right. I'm glad it caught your eye. You were that meme, right, where it's passing you by and you're taking a look at it as you go past. I'm going to try to convince you and the whole audience that maybe we should be going to C in this situation, and not necessarily. There are other potential options, but out of these, C might be something that we want to consider. But again, make me prove that to you, and that's what I'm going to try to do here moving forward. Let's start off by just high-level overview of the characteristics of those new antimicrobials that we have potentially used for HABP. And as you'll see, all of these agents, but the last one listed, actually has an indication for HABP because there are clinical trial data, and we're going to talk about that a little bit here shortly. So the first one, this came out late 2014, is ceftolozane tazobactam. Again, tazobactam you know and love from Zos and fame. The difference here is that you got ceftolozane, and the real claim to fame of this drug, and again, this is just going to be a high-level overview of these agents, is that it's very active against drug-resistant Pseudomonas. So I'm going to show you some data about that a little bit later. Of note, because tazobactam is there, you actually have really good in vitro activity against ESBL-producing Enterobacterales as well. But again, not going to be the focus of where we predominantly look to that drug. The second is ceftazidime avibactam. Again, this came out in 2015. Ceftazidime is a drug that you know and probably have mixed feelings towards. The big difference here is the addition of avibactam. This was a revolutionary beta-lactamase inhibitor. This is the first non-beta-lactam beta-lactamase inhibitor. It's called a DBO. And really the claim to fame of this beta-lactamase inhibitor and where it was initially used is that it inhibits KPC. Of note, it also inhibits OXA48, and that's unique to avibactam. And we'll talk about that when we talk about treatment pathways. But as it relates to the talk about Pseudomonas, a big driver of ceftazidime resistance is actually AMP-C hyperproduction. And avibactam can inhibit that as well. So as we're going to see, you get good in vitro activity there as well. Imipenem relebactam came out a few years back. Imipenem, again, is a drug that you know. The difference here is the addition of relebactam. Relebactam is actually in the same class as avibactam. And so what it was really developed for was for KPC inhibition, and it does a good job of that. So it's active against KPC. But what you'll actually find, and again, I'll show you some data on that here shortly, is that it ends up having very good in vitro activity against Pseudomonas, including drug-resistant Pseudomonas as well. Cefiderocol is the unique player to this. So this is not a beta-lactamase inhibitor. Cefiderocol is a cephalosporin base with a siderophore attached to it. And basically what that does is that allows it to kind of exploit the iron uptake pathway, get high concentrations of active beta-lactam at the site of activity, at that peptidoglycan. And what you actually see, kind of unique to cefiderocol, is that in addition to activity against CRE and carbapenem-resistant Pseudomonas, you also see activity against Acinetobacter baumannii, which is unique to this list. And we're going to come back to that a little bit later. And then meropenem avibactam. Again, meropenem is a drug you know and probably love. I'm a big fan of meropenem. The difference here is that we're adding our only boronic acid-based beta-lactamase inhibitor, which is avibactam. And all I want you guys to think about when you think about this drug is avibactam was synthetically designed to inhibit KPC, and it does it really freaking well. And I would say that it should be considered the drug of choice for KPC infections. We're going to come back to that in a second. And so, again, we're going to focus on these heavily towards Pseudomonas in this presentation today, just because that's our patient case. But I do think it's important to know where these novel agents come into play for the treatment of other resistant gram-negatives. And one thing that's really nice is over the past year, the Infectious Disease Society of America, and actually the European group has done this as well, they actually have guidance documents out there for the treatment of drug-resistant gram-negative organisms. So you can see that citation. Pranita Tama leads that group. I encourage you to take a look at that. There's a lot of great data in there, the evidence that supports these recommendations. Again, high-level overview here. When you're talking about carbapenem-resistant Enterobacterales, again, the important thing that you need to keep in mind, and this is why Dr. Abbo talked about it for such a good chunk of our discussion today, is it all depends on the mechanism, because these inhibitors have different activity against different mechanisms. So if KPC is identified, you can see there Cazavi, imipenem, relebactam, or meropenem are all options. Again, I personally believe meropenem avibactam is kind of ideal for this because it's really optimized toward KPC. If it's OXA48-like, the only preferred option is ceftazidime avibactam. Again, remember, avibactam is unique in that it actually inhibits OXA48. Relebactam, avibactam do not do that. You'll note that alternatives in both of these situations are cefiderocol. We'll talk a little bit later about why it's an alternative and not a preferred agent. And then the real challenging one that we have to deal with, and I will tell you that just in Michigan, we're seeing this more as a mechanism of CRE, are our metallo-beta-lactamases because our inhibitors that are approved don't inhibit these. And so our options for first-line options there are a little bit more limited. Either ceftolozane, which again is relatively stable to that beta-lactamase because of the concentrations you get at the site of activity because of that, iron pathway uptake. Or you can use ceftazidime avibactam in combination with aztreonam. And this is a really cool mechanism of why you can use this. So one thing that's unique about aztreonam is that unlike other beta-lactams, it's actually stable to hydrolysis by metallo-beta-lactamase. The problem is that metallo-beta-lactamases don't come alone. They usually come with any number of ESBLs or AMP-C, and so those things will take out aztreonam. So what you actually do is you give the avicaz. The avibactam is there to inhibit everything else, and in that situation, aztreonam can do its thing. So again, the point I would just get at here is that it's really important to know your mechanism because it's going to direct what you're going to give. And then real brief overview before, again, we do the deep dive into Pseudomonas. Talking about Acinetobacter, unfortunately, we still don't have really good options. Again, I encourage you to take a look at this guidance document. It really goes through all of the evidence or lack thereof in a lot of situations. The two things that I would highlight here is that one, the guideline authors or the expert recommendations really prefer high-dose ampicillin sulbactam if it's an option. Again, sulbactam can retain activity even in the setting of carbapenem resistance sometimes. And so preferring that when it's an option. And then the other thing I would just highlight is that they really focus on combining multiple active agents when you have a moderate to severe infection. And the reason for that, guys, is simple. None of them seem to perform too well by themselves. And so even though there's not a great evidence base behind that, it's really trying to improve outcomes in a patient population that has pretty poor patient outcomes. And again, what those two drugs are, there's a lot of debate out there. Again, I would encourage you to look at the guidance document for all those specifics. But the key things I just want to highlight are the preference for sulbactam and then the use of combination therapy. But what I want to spend the rest of my time on here today is really the deep dive into talking about Pseudomonas, because that's what our patient has. And that's where I think some of these intricacies come into play. And so what I'm going to do for the novel agents is we're going to focus on the in vitro activity. And we're also going to talk about the clinical trial data for pneumonia and how that can help inform what we do. But before I get to those new drugs, remember I said I promised you guys that I was going to convince you that in a patient case like the one we're talking about, we might want to think about these new agents. And so what you're looking at here is, again, this is just US data from the last couple of years before the pandemic. These are ICU patients with pneumonia, and it's looking at susceptibility profiles of Pseudomonas isolates. And what I'll bring your attention to in this slide is that middle part. So you see PIP, tazo, cefepime, and meropenem. And I think this is pretty consistent with what most of you will see in the United States, is that pick whichever one you want, you're probably looking at about 20% resistance. Where people, I think, get themselves into trouble with Pseudomonas resistance is they say, okay, maybe PIP, tazo isn't a good option in Scott because he had recent exposure. But if I switch over to cefepime or meropenem, I still have an 80% chance of getting it right? So you might make that move. But what I really want to highlight, and it's why Dr. Abbo spent so much time talking about the complexities in beta-lactam resistance and Pseudomonas aeruginosa, is that co-resistance or cross-resistance across those traditional beta-lactams is actually quite common because they share those mechanisms of resistance. And often when one is present, multiple of them are present. And so these are data that we had at Michigan Medicine. Again, there are others out there that show this, but I want to use this as a proof of concept. So focus right now on the left side of the screen. And so what you're looking at, just to orient you, are MIC distributions to meropenem. Again, so if you look at the x-axis, those are MIC distributions. The y-axis is the cumulative percent of Pseudomonads that are inhibited at those increasing MICs. And so the first thing I want you to see is look at the blue line. So basically at the break point, that's what the dashed line there is of 2. What do we see? About 80% susceptibility to meropenem. Again, that's consistent with everything else we've talked about so far. But what I want to highlight for you guys, and what I think you really need to be aware of, is look at the other two lines, the Christmassy colors that we see there. Those are the isolates that are resistant to either red, which is cefepime, or green, which is pip-tazo, what their susceptibilities are to meropenem. And what you can see is once you lose one, you pretty much lose the others as well. You're talking about only 30% susceptibility. So really, I would argue that it's not escalating when you're talking about Pseudomonas going from cefepime or pip-tazo to meropenem, because the likelihood is if those primary drugs don't work, neither will meropenem. And so if that's the case, the question becomes, okay, now I have to prove to you that you could consider some of these novel therapies, that we don't just see that same exact thing occur. And so let's start off by talking about ceftolozane tazobactam. And what I want to do for these drugs, again, we'll look at it in vitro susceptibility, and then we'll look at it from a standpoint of clinical trial data. And so what you are looking at here, again, is ICU data in the United States, looking at Pseudomonas aeruginosa. And just to orient you to the x-axis, you're looking at different types of beta-lactam resistance, either pip-tazo, cefepime, ceftazidime, or meropenem non-susceptibility. They all show the same thing. Let's just use the pip-tazo one as our example. So what do you see? Again, similar to what we looked at a few slides ago, when pip-tazo is out, you see very low susceptibility rates to traditional agents. Pip-tazo, cefepime, ceftaz, those first three colors. But what you see, due to ceftolozane tazobactam's relative stability to those mechanisms of resistance, is really good in vitro activity in that situation. So again, we see in vitro activity, but that's not everything. We also want to know that the drug works. And so I want to, again, I'm talking very briefly about these studies, but again, the reference is there in the bottom left corner. So if you want to see the details, this is the Aspect MP study, which compared ceftolozane tazobactam to meropenem for either VAP or ventilated hospital-acquired pneumonia, those kind of nastiest patients, as Keith taught us about a little bit earlier. Again, don't get hung up on the numbers here. That's not my goal. All I want you to see is that meropenem, a drug that most consider to be a good drug for the treatment of pneumonia, ceftolozane tazobactam was non-inferior in that situation. One thing that's unique about ceftolozane tazobactam, though, is that because we've kind of had it the longest as our kind of go-to drug for drug-resistant Pseudomonas, there's actually real-world observational data showing its efficacy in this situation as well. So what you're looking at here is a retrospective multi-center comparative effectiveness study comparing ceftolozane tazobactam, so again, a novel beta-lactam to target these resistant isolates, versus what we'd have to use if we didn't have these drugs, polymyxins or aminoglycosides. This was a multi-centered study across Michigan and Ohio. As you can see, there are a very sick population. Majority had VAP, majority in the ICU, and about half of them were either in severe sepsis or septic shock. And the key thing I want you to see there is that compared to those historical options, therapy with ceftolozane tazobactam was associated with improved efficacy and significantly decreased toxicity. And so what we're seeing is data to support that this in vitro activity actually matters. The second drug I want to talk about here is ceftazidime avibactam. Again, just to orient you to this slide, looking at that first column, you're looking at all pseudomonads and then increasing resistance, multi-drug resistant, extensively drug resistant. But just look over at the right-hand column now, and as you can see, unlike drugs like cefepime or pip-tazo or meropenem, even in the setting of multi and extensively drug resistance, you're seeing good in vitro activity. So again, another thing to consider for these patients. And what's nice is that ceftazidime avibactam was also studied in the REPROVE trial for the treatment of HABP. And so again, you're looking at the study here. I will not get into the specifics. You can see the reference down there for Lancet ID in 2018. Bottom line, compared to meropenem, and we once again saw non-inferiority. So we do have data looking at pneumonia as well. The third novel agent that I want to touch on is imipenem relebactam. Again, you're seeing the same types of data being presented here. As you kind of go down the different rows here, you're looking at increased resistance to 3, 4, 5, and 6 different agents. As you can see in the 4 columns on the right side of your screen, For traditional anti-pseudomonals, you see them drop off very quickly, but imipenem relebactam, again, retains excellent in vitro susceptibility. So something else to be considering from an in vitro standpoint. What's nice about imipenem relebactam is we got a lot of evidence to support its use as well. So this is the HABP trial for imirel compared to pip/tazo. Not going to get into the specifics. You can see the citation there by Titov and colleagues in CID last year. Bottom line, non-inferiority shown to a drug that is commonly used for the treatment of HABP. So we have RCT data in that situation. One thing that's kind of unique to imipenem relebactam is there's also the Restore IMI-1 trial. You can see the reference to that down in the bottom left-hand corner as well. Very small study, but guys, what's unique about this is that this was actually a study that was targeting carbapenem-resistant infections, and the majority of patients in this trial had carbapenem-resistant Pseudomonas. And so even though the numbers are too small, you can see there are 30 patients in the whole trial, you can still see this huge signal toward improved efficacy. Note the blue bars look better than the red ones, and decreased toxicity. So similar to ceftolozane tazobactam, you at least have some evidence in this space supporting this. And then the other agent that we think about potentially using in these patients is ceftazidime. And so as you can see here, ceftazidime has excellent in vitro activity against carbapenem-resistant Pseudomonas. In fact, it's probably, if you look at the antibiogram at your institution, it's probably going to have the highest degree of in vitro susceptibility. You can often see susceptibility even when some of the other novel agents are resistant. Again, that's related to the fact that it's able to get in by this alternative mechanism to get into the cell. You get high concentrations at that site of activity. So encouraging, right? Good news. More good news is that it was actually studied in an RCT against high-dose meropenem, the APEX NP trial, comparing patients who have VABP. And again, just high level, what do you see? Non-inferiority to high-dose meropenem. So very good, right? All this looks great. So why is it not preferred in all of those recommendations that we looked about so far? And the big concern here comes from the credible CR trial. So this study was published in 2021 in Lancet ID. The reference is there below. I would encourage you to take a look at this study to really understand these data. But just so you know, this was another one of those directed pathogen studies comparing ceftazidime to best available therapy. And so best available therapy was whatever the physician wanted to give the patient if they couldn't give ceftazidime. It was predominantly polymyxin-based therapy. You can see here just under 100 patients ended up being included in this trial. The big thing that I want you to see here in this study, two things I would highlight is one, predominantly carbapenem-resistant Acinetobacter included, although there's a good chunk of Enterobacterales and Pseudomonas as well. But look at the bottom right-hand part of the screen here. You can see here that even though this was not statistically significant, there was this signal or this concern of potential increased mortality with ceftazidime. Again, that might mean nothing. That might need something, but it's the kind of thing that does give a little bit of pause. And the reason you don't see ceftazidime in the IDSA guidance document as a preferred therapy. And so how does this relate to the IDSA guidance document for the treatment of difficult to treat resistant Pseudomonas? Again, difficult to treat resistance basically just means all of those first line options are out the window. And as you can see here, and it kind of goes hand in hand with what we talked about, right, guys? The preferred options are ceftazidime, ceftolozane tazobactam, or imipenem relebactam. You'll note that an alternative therapy is ceftazidime. Again, only alternative because of what we saw in the credible CR. And the other thing I'll note here is what you don't see on this slide is meropenem avibactam. Remember what we talked about earlier, guys? That's really a drug that's targeting KPC. It's not something that we really consider for DTR Pseudomonas. And the reason is that avibactam doesn't really add a lot to meropenem. And it's related to, as Dr. Abbo said before, mechanisms of carbapenem resistance to meropenem are predominantly a combination of porn reduction and efflux. And if you add a beta-lactamase inhibitor, it doesn't really do anything. And so really the preferred options are those three that you see there on your screen. And then one thing I have to say, I'll lose my ID pharmacist card, if I don't talk about this at least a little bit. And that said, again, we're talking about aggressive therapy, and I believe strongly in it. Just like I said, I would give this patient ceftolozane tazobactam based off what we knew. But it's also important to remember just regular stewardship pearls still apply to these patients as well, right? And that's things like duration of therapy. There's nothing different about treating a resistant organism, assuming you got it right early in therapy. If there are oral options, such as a quinolone, it's appropriate to transition as long as it makes sense for that patient. And then, as Dr. Abbo talked about, using those rapid diagnostics, using traditional microbiology, and getting off the other therapies. We talked about giving VANC, CT, and tobramycin, but once you know it's susceptible to ceftolozane tazobactam, the VANC and tobramycin can come off in that situation. And so those back-end stewardship things become really important. And so I want to bring my panelists back in here just to get their experience. And so I'll start with you, Keith, and you see the questions that are listed here, but just in general, I'm curious to what's your experience with the newer agents? Are you using them a lot? Has it been positive? Anything you want our audience to know about that?
Yeah, I've had a pretty, good experience, and by good, I mean a relatively frequent use, and generally the drug's been well tolerated. I have not used cefiderocol yet, but the others I have used. I will use them mostly as salvage therapy, or when maybe salvage isn't a great optimal word, but definitive therapy when results come back, either RDT results, or in some cases when the culture shows that they're either the only options available or the best options. I will try to minimize duration of therapy, that not only with those agents, but all agents. So for HABP, if you get effective therapy on board and patients respond, there's not much reason to go beyond 7 or 8 days. I will say for some complicated patients who don't respond very quickly, particularly with Pseudomonas acinetobacter, I might go a little bit longer. I look for resolution of symptoms, whether that be fever, whether that be oxygenation improvement, whether that white count plays a role. The nice thing about the new agents that you've discussed, Jason, is they're really all, I believe all the ones we talked about were beta-lactams, and they have similar side effects as the other beta-lactams, and whether that is GI side effects or allergies. Some people have hypersensitivity reactions, although not a high percentage, or rash, but generally relatively well tolerated compared to what we typically see with our treatments. I try to de-escalate therapy as quickly as possible. I think with rapid diagnostics, if you don't detect Pseudomonas, you don't detect MRSA, you often can de-escalate pretty quickly, particularly if a patient seems to be responding to therapy. And I think, sometimes with hospital-acquired pneumonia outside the ICU, it's tricky because you don't have a good specimen they don't have positive blood cultures, you don't have a good respiratory specimen. So you don't have that culture to base the escalation on. There, I will often base it on their risk factors for resistant organisms, and also how well they're doing clinically and how stable they are. These are excellent questions. Clearly no single right answer, but I'm very interested in what Dr. Abbo thinks.
Oh, I absolutely agree with everything that you have said. We treat the patient. We don't just treat the bugs, right? So the fact that a culture is still positive, but the oxygenation is down, patient is breathing better, secretions are better, imaging is better, that doesn't mean you need to extend therapy just because I keep swabbing the trach aspirate and it's positive. So always look at the patient. I always say that the best de-escalation is stopping antibiotic therapy. So if at 7 days you're better, it's not about switching to amstelbactam. It's about stopping therapy when you don't need it anymore. So in general, we try to treat 7 days. But again, if the patient is better sooner, we may stop sooner. Or if the patient needs it a little longer, we'll treat a little longer, depending on that individual.
Amen. I love that. The best de-escalation is discontinuation. I completely agree with that. Thank you both for those great responses. And Keith, I'm going to hand it back over to you to take us home.
I'm getting very excited for a Q&A session. So I was sort of triaging some of the questions there. I don't have much more that I want to talk about, but there are a few other questions that I would like to discuss with my esteemed colleagues before wrapping things up, and then we can jump in on the Q&A session. I guess in our current patient, in Scott, what could we have done differently? And let's say, in a dream ICU, if you had the technology that you wanted, or you had the antibiograms that you wanted, you had the antibiotics that you wanted. How could we have improved his time to effective therapy? What sort of clinical cues might you have used? And second part to that question is, Jason, you made an excellent case that a newer agent like CT, ceftolozane, tazobactam, would have been a really good option for this patient. What do you think we need to do to, both Lilian and I think, shied away from the CT, the choice. What do you think we can do to get people thinking more openly about reaching for these agents? So two-part question. What would you have done differently to improve effective therapy earlier in this patient? And also for patients in general, what do you think we can do to get word out and to get uptake of these newer agents to a greater extent?
So that's me.
That's to you, Jason.
That's to me. So two-part question. First part is, again, a lot of things that we discussed, I would just reiterate. I think in that empiric setting, there were reasons to think, right, that the norm wasn't going to be good, right? And so really giving that critical analysis, thinking of that patient's antibiotic exposures, their severity of illness, and not being afraid to be aggressive. And I know that we'll come back to this in part 2 of the question, but not being afraid to be aggressive up front. Again, 2 days of a drug is not going to harm. So again, you'd rather get it right. You showed that very clearly in that situation. And then if you think about as we kind of progress in that case, we learned from the rapid diagnostic, we had even potential clinical deterioration that was occurring. And we talked about it earlier, but I would just re-emphasize that know what the RDTs tell you and what they don't tell you, right? Again, I think that there is a knee jerk that people have if they see Pseudomonas no carbapenemase, that meropenem is a good option in that situation. And it's really not informative to that conversation at all. And so, again, uptake of those tests, I do think that, and Lilian, you kind of hinted at this a little bit, and we've talked about it before, is that, you have to pick the right patients for those types of tests, because particularly when you start talking about the RDT, lower respiratory tract infection panels, they get pretty pricey. And you really need to think about who's going to benefit. Again, a patient like this is ideal. Because they have risk factors for resistance, they're worsening, you're pretty confident they have a pneumonia, it's a perfect kind of patient. So I think that that's important things that I would say there. And then key to the second part, I think it's on us as stewards to advocate for these drugs. I really do. I think the most important stewardship, and I would say the 2 most important stewardship interventions are decreasing time to appropriate therapy and dose optimization. And it's the most important intervention I ever make on a day-to-day basis is escalation of antibiotics. I can always de-escalate 2 days later and get that off. And so I really think it's on us to understand these drugs, understand the need for them at our institution. Again, you might not need all of these at your institution. Some of them do get redundant. You might not need every single one of them. And I think that it's understanding what's going on at your institution and making that case for them. I honestly think that's our job and that's our role as stewards.
Lilian.
I agree with everything. I am also all tradition, right? I think that if you can get a gram stain done in 5 minutes, go get that sputum, take it to the lab and see what's going on. Because maybe it's full of yeast, or maybe it's all gram positives, or maybe all gram negatives. So that will give you a quick answer very quickly to start your therapy within minutes. It's accessible everywhere in the world, or most parts of the world. The second thing is now you need to think, okay, now I want fancy molecular diagnostic tests. What can I get? What will give me the biggest bang for my buck? Many of us have the community-acquired pneumonia respiratory viral panels, and we still see people, continuing broad-spectrum antibiotics. So I would say use it with caution. You need to have algorithms. If you're going to bring this pneumonia panel, how is this going to help me? Who is going to be acting on the results? What if everything is negative? Does that mean the patient doesn't have pneumonia when they clinically have pneumonia? And if it's positive, am I going to use this to timely escalate and de-escalate therapy like, both of you just mentioned? And then also, what's the frequency of these rapid diagnostic tests? Because I find that one of my roles in diagnostic stewardship is also creating hard stops for people to pause and think. It's not about getting a daily PCR culture. Even with COVID, I've seen like almost interdaily COVID PCRs when we first had it, and we had to put a hard stop. So again, how to use them? What are you going to do with the information? The clinical clues, like all of you mentioned, you really need to look at the antimicrobial history and the individual risk factors. And then what's going on in your ICU. And then talk to your colleagues, because you may just be the ID consultant. So you always need to partner with the primary team taking care of that unit, if it's an open or a closed unit, really talking through the teams, what can we do to optimize care? And then the other, strategies, how do we use these drugs? It's a catch-22. On one hand, we want people to use the right drug at the right time. On the other hand, I don't want every patient on broad spectrum antibiotics. I tell people, yes, putting everyone on meropenem will hit everything, right? But it's not always the right choice. So like Jason mentioned, yes, we need to use these new drugs. We need to use them wisely, but it's patient selection. And again, yes, you can always de-escalate the next day. Sometimes you don't know to which of the 4 agents that you added. So then the people are resistant to de-escalate. Like, oh, but they responded to all 4. I don't want to stop the micafungin. So maybe that only happens in my hospital.
I think everyone knows that who's on this call.
Okay, thank you guys. Excellent answers. I just want to wrap up with a final slide. Some key points from today's talk. HAP and VAP are bad players. They are frequent. They contribute significant morbidity, mortality, duration of hospitalization, hospital costs. All these are associated in a bad way with HAP, VAP, and particularly those due to resistant gram-negative organisms. Gram-negatives and resistant gram-negatives are unusually common and frequent in many parts of the world in HAP, VAP. We are seeing new antimicrobial agents since 2016. We've really seen a revolution in agents that are available. Jason did a really nice job covering these. Many of these are recommended as treatment options, as potential treatment options for HAP-VAP. IDSA guidance is very useful. There is the HAP-VAP guidelines in 2016, and there's also the multi-drug resistant gram-negative treatment guidelines that was recently published just, I think, over a year ago. Antibiograms should be available at most hospitals, and you can get fancy and have different types of antibiograms. Algorithms, which I think Lilian gave excellent examples of, and Jason also talked these up. And I wouldn't forget about RDTs. I think rapid diagnostic testing for HAP-VAP is going to become more in vogue and probably become more affordable in the not too distant future. And I think all of these can be used in a structured, quality improvement driven, efficient way to improve the time to effective therapy, even for resistant pathogens, and improve patient outcomes and decrease patient suffering. So I want to thank my colleagues for their excellent slides and discussions. But now is the really fun part. Now we get to your questions. This is a question from Rachel Larry. Thank you very much for your question. Lilian, I'm going to give this one to you. I am at a smaller academic institution where we are limited by number of isolates. Is an all ICU antibiogram, medical plus surgical plus neuro, better than no ICU antibiogram at all?
I think so. And again, it depends on your patient population. But if we have community hospitals and we have large academic hospitals, and we do merge in the community hospitals, the ICUs, the antimicrobial use, and the patterns might be similar. And I think what you don't want to mix is your emergency department with your obstetrics, GYN unit, and then the ICU. So I do think if you have a small hospital, merging all ICUs makes sense.
Awesome. The next question I will take, but I also am going to let Jason chime in. It says, what would you consider proper empiric therapy for pneumonia secondary to carbapenem-resistant Acinetobacter baumannii while we wait for susceptibilities? Besides relying on the antibiogram, any recommendations? Well, first of all, I think it's important to note that cilastatin-based treatment is actually preferred in those 2021 IDSA guidance. So in the U.S., we only get cilastatin with cilastatin, but cilastatin, high dose, aggressive cilastatin use, you can often use as monotherapy. I've had good experiences with this. So I think that should be a cornerstone of treatment. Unfortunately, with XDR Acinetobacter, we can see resistance to both of these. And this is where you start looking at it while you're waiting for susceptibilities. A drug like ceftolozane, I know clinically we're not convinced that it's a great Acinetobacter drug, but certainly as part of a combination, potentially with tigecycline, potentially with aminoglycoside. Polymyxins often retain activity but are quite toxic and don't have favorable pharmacokinetics in the lungs. So, probably something while you're waiting, maybe something like ceftolozane in combination with either minocycline or tigecycline. Jason, do you have any thoughts?
It's a hard question because there's no right answer, and it almost feels like every answer is wrong, to be honest with you. It's one of my least favorite questions. I think that you do need some appreciation for how the different tetracyclines fare at your institution. Often these patients do have a history of Acinetobacter, or it's floating around the unit or the nursing home or wherever, so you can get some idea. Because there's some intricacies to that minnow-tiggy question, because in my opinion, both of those breakpoints are wrong, and it depends on where the MICs really lie in that situation. If I knew it was going to be even intermediate, I'd like cilastatin to be part of that. I have grown kind of fond of ceftazidime plus cilastatin. But in the empiric setting, it could be that combination. It could be ceftazidime plus minnow or tiggy. I just try as hard as I can to get some piece of information that can help inform me of what's most likely to be active. But I will tell you that I almost never recommend a polymyxin in those patients anymore personally.
I want to mention something, and I would be cautious with amino-tiggy, and especially tiggy. You'd also want to know if it's just pneumonia or if the patient is septic and bacteremic. You want to use a drug that if you're going to use as monotherapy, you need to make sure it has good systemic penetration, right? Not just pulmonary penetration or vice versa. If you're going to use a drug that has good systemic, you want to make sure it also gets into the lungs. So I would use those, like both of you mentioned, in combination.
Excellent point, Lilian. Thanks for, and while we have you, this might be a quickie because I don't know the answer, but you might. Is there a specific application that can analyze the data in the microbiology lab to create antibiogram in real time? I don't know what that application is. Jason or Lilian first, are you aware of anything?
It's not in the microlab. So the microlab uses different tools. WhoNet is one of them. Your Vitek instrument might be able to generate some reports, or if you send out to Quest, Quest might be able to send us some things. Now, what we use, it's not in the microlab, it's on the stewardship and the infection control. We use Vigilance. There are other softwares that are called data mining softwares. Epic may have their own version. Teradoc is another one. I don't favor any brand, but you really need to look. There are some commercial softwares that can integrate to your medical record, and they abstract from the pharmacy and they abstract from the microlab, and they sort of merge that information. So yes, I can get antibiograms on demand through Vigilance. I can just pick any unit of the hospital. I can select the time frame. I can say January 1st to February 5th, and I can generate an antibiogram in that period of time, or I can go back as 1, 2, 3 years and look at different trends. So yes, there are some companies that have done some pretty neat work, and you can do it by organism, by location. So that's what we use.
Next question is from Marie. How much variation do you find with your unit-specific antibiograms compared to national averages? I will answer first saying that in Detroit, we saw, I think, higher rates among all gram-negatives across the board, whether it's Enterobacteriaceae for CRE and ESBLs, whether it was Acinetobacter, whether it was Pseudomonas. I'd say at U of M and now in New Jersey, probably our rates of resistance to antibiotics, the Pseudomonas, are probably higher than national averages, but I think we're about pretty close to spot on with the others. I don't know, Jason, what are your thoughts?
Yeah, so I would say that I've seen every version of this, and on the average, it ends up being on the average. But if you go down to the unit or the hospital or the health system, it can vary a good bit. Keith, I think back to when we were in Detroit, the burn ICU in particular was just brutal, just because of the patient population. There was nothing being done incorrectly or anything. But I've also spoke with people at small community hospitals that they look beautiful. Their isolates look beautifully susceptible, and you wouldn't want to give combination therapy empirically in those situations. So I do think it's important that you look at it at the institutional level, because it can go either way. You might be able to get away with one drug, or you might need pretty aggressive empiric therapy.
And how about you, Lilian?
Absolutely. So I'm biased. I'm in the county hospital in Miami. So we have 1,500 beds. And then we have within our health system 3 additional community hospitals. When he first started doing stewardship, our lab was merging the pediatric antibiogram with outpatient isolates, with ER, and with the hospital. So everything looked okay. We have a resistance. When we split it, pediatric now looks amazing because there are a little different situations. We don't see as much multi-drug resistance in PD. But when we look at our unit-specific antibiograms, we have way more resistance than reported nationally in other areas. And I have a large burn trauma unit, very long length of stay. We have a very big transplant program, over 600 solid organ transplants a year, bone marrow. So we have very unique populations that our typical community hospitals don't have. And the community hospitals, just like Jason said, way more susceptibility. And some of them, I would say, yeah, in some places you may want to use penicillin. You don't want to use another drug. So you do need to look at your individual area where you are geographically, and even within the same city and the same hospital, very different locations.
All right, we still have a lot of questions, so we're going to get rapid fire. When you initiate tobramycin for pneumonia, are you giving a single dose like 7 mg per kg or daily dosing until further diagnostic data comes back? In our healthcare system, we have the habit of using a times 1 dose to potentially buy time due to the bactericidal nature and post-antibiotic effect. That's from Benjamin. I will say, first of all, the single daily dose, if patients qualify per our institutional guidelines, I absolutely would go with that. And, as Lilian said, you treat the patient, right? So if the patient's doing better the next day and I'm still waiting on results back, I might hold off on redosing. If they're still septic or, still not improving at all, I probably would continue it at least another day. You should have something back within a few days. Jason, do you have anything to add there?
Yes. The good news is that the sickest patients are usually in some degree of acute kidney injury. And so you kind of get there anyway, right? Because the drug does not clear and it's an AUC-based drug and you get exposures that you need anyway. But if the patient has normal renal function, I would actually say even if they were responding, I don't know that they're not responding to the aminoglycosides. I'd redose it. A dose or two of that drug I'm not concerned about.
Is there any superiority of ceftolozane tazobactam over ceftazidime avibactam for Pseudomonas if the isolate is susceptible to both antibiotics? That's from Paulette. Great question. I know of no data that would suggest that one is superior to the other. I think they both should work. Jason, do you want to add anything to that?
Yeah, you should come to the Farm Geek for this one for sure. So I think CT has a lot of theoretical advantages that I would prefer it. One is you only care about the exposure of the cephalosporin. The tazobactam isn't doing anything, and the PKPD is beautiful with CT. Cas-Avi, it's often borderline susceptible. Avibactam exposures come into play in addition to ceftaz. There's just a lot of muck there. And as we saw, there's some real world evidence to support CT as well. So I do think they're both completely acceptable options, but because it's usually more potent, because I have more comfort with CT, that would be what I would prefer.
I completely agree. We actually, first line is Toltezo. However, with the national shortage that we had, that's finally being resolved, we were using a lot of Taz-Avi. So yes,
Okay.
Pseudomonas, if you know Pseudomonas.
We're moving, team. We're moving. We're going to try to get through all
this. Like 3 minutes left.
Lilian, in the absence of antibiogram data and susceptibilities, what would you use for empiric treatment of moderate to severe Acinetobacter infections?
Oh my God. Again, I think we already sort of answered that question. And
if it's susceptible, if you don't have anything back.
If it's susceptible and I don't have resistance, I would use amsulbactam.
But I think carbapenems are acceptable as well. But don't forget about the amsulbactam, people. It's carbapenem sparing as well.
I would not use a carbapenem if I could use a drug.
Very good. Thank you. Jason Pogue, how solid is the evidence, clinical evidence, for high-dose amsulbactam versus PrAD?
It's awful. I mean, any Acinetobacter evidence is awful, and this is no different. It's largely a PK-based argument that you're making.
Lilian, for hospitals that do not have Avicaz or Jabax in the formulary or the microlab, and they're not able to test susceptibility, would you recommend high-dose or extended infusion meropenem?
Yeah, so extended infusion of meropenem monotherapy may be a catch. If you know that it's a carbapenemase producer, I don't know that you're going to be able to overcome that resistance of pori mutation or of an efflux pump. High doses maybe. What we have done in the past when we didn't have these new drugs, we use ertapenem in combination with an extended infusion of meropenem. We have abandoned that practice and we only did it as a kamikaze. You send the ertapenem to sort of saturate, the enzymes and then try to get the meropenem to penetrate. This is all theoretical case reports. I would say if you don't have these drugs, work with your PNT. If you're in the United States, try to get it. If you're in other parts of the world, there's some countries that already have these drugs. And there are good reasons why to bring them on your formulary.
There we go. We're getting there. Next question is from Jasmine. If the patient's getting worse on first-line anti-pseudomonal beta-lactams, would you first obtain cultures before broadening to some of the newer agents, such as ceftolozane, tazobactam? I will take that absolutely. Absolutely want to get cultures, but you don't want to wait for those cultures if the patient's getting worse. You want to sort of empirically change therapy while you wait for those culture results. But I absolutely would get cultures on a failing patient clinically. The next question for the presenters that discuss using newer agents, are you having the lab test susceptibility? How quickly is the turnaround on that for your lab? Jason Pogue, you are on the clock.
2 points that I'd make. First off, I live in La La Land at the University of Michigan where we routinely test all of them. So that's atypical. What I would recommend if that's not feasible is get a collection of your nasty suits and test them to all the novel agents. Get an idea what they look like. That can drive you empirically. But if you're going to use the drug in an actual patient, you should test it and see if it's susceptible.
Awesome. Lilian, do you have all three agents, CT, ceftazidime, avibactam, and imurel on the formulary? If not, which one would you choose and why? And I suppose
we have all, and because we swim in resistance, I actually get access to these drugs before they even come on the market. So we get to sort of pre-test them through INDs and compassionate use. So we've used them all. We have the algorithms that I show. Now we're using broth microdilution. The Sensititer has an automated panel. You can test all drugs at the same time. If you don't have the benefit of that, your lab can do this diffusion or e-test, and you can actually test these drugs. But microdilution will give you the most accurate method if you can get it and if you have a reliable microlab. If not, like you just said, like Jason mentioned, partner with other institutions who might be able to help you. There are commercial labs or research labs that might be willing to help you with some of these tough situations.
Jason, any use of sulbactam, durlobactam for crab?
I have not used it. I anxiously awaiting A, seeing those data because they looked good in press release form, and B, that drug subsequently becoming available.
Okay. Lilian, how to differentiate between colonization and true infection in HABP? Any just quick tips that you can provide?
Again, you look at the patient, and in the hardest area to look at the patient is trauma, because some of these patients have been there for a long time. They have pulmonary lung injuries, pulmonary edema, and then ventilator settings may be going up with effusions. So I always say, look at the patient, look at your clinical parameters. Some people have used procalcitonin. If your procalcitonin is high, most likely it's infection. In colonization, we should not be seeing high procalcitonins, eukaryote CBC. The respiratory secretions, if there are any changes in your ventilator settings, basic clinical skills, I would say, are what we usually typically use.
Thank you very much to our faculty, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.